Assalamu alaikum. Good morning, good afternoon, good evening, depending on your time zone. I hope all is well with every single one of you. Let's do today's lecture, a very interesting topic, most commonly tested topic. It's very high yield in the licensing exam and pretty easy too, and interesting at the same time. So PCOS or polycystic ovarian syndrome. The definition: a complex endocrine disorder characterized by ovulatory dysfunction, hyperandrogenism, and polycystic ovarian morphology. Diagnosed clinically using Rotterdam criteria. Rotterdam criteria is the easy way to remember. I think I didn't make a mnemonic for it, which goes as PCO. I think this way you can easily remember it. PCO. P stands for, let me change the color, make it bold. All right. So the PCO, P stands for polycystic ovaries on ultrasound, which will be more than 12 follicles, or ovarian volume more than 10 milliliter. C stands for clinical or biochemical hyperandrogenism, symptoms like hirsutism, acne, or elevated androgen, which shows elevated androgen. Oligo or anovulation, cycles more than 35 days. It means the cycle happened over 35 days, or there will be a total of less than 8 cycles per year. So if you have 2 out of these 3 PCO, it means you have PCOS. And we should remember that this is an exclusion diagnosis. So you have to do the TSH, you have to do the prolactin, you have to do the 17-hydroxyprogesterone, and you have to rule out the Cushing syndrome and also androgen secreting tumor. So basically you have to exclude the other issues before doing imaging. So imaging or transvaginal ultrasound always once the lab workup is done. For the lab workup, so basically people or the patient with the polycystic ovarian syndrome, they usually have insulin resistance. In order to do the screening for insulin resistance, we have 2 options: hemoglobin A1C and OGTT. But OGTT is preferred. So do not waste your time on doing the hemoglobin A1C or fasting glucose. So the best way to do it, since it shows the tolerance, it is more specific for insulin resistant screening, go with that 75-gram OGTT. And lipid profile for sure, because these patients will have hyperlipidemia as well. For hormonal free testosterone, supposed to be checked: TSH, prolactin, 17, hydroxyprogesterone, and transvaginal or transabdominal ultrasound, again, after lab workup. For the management, the lifestyle modification is the best first choice for all: weight loss, around 5 to 10%, diet, exercise. It will improve the ovulation and insulin sensitivity. In terms of pharmacological treatment, menstruation regulation, endometrial protection, so OCP always come first. But depending on the patient, we have to be very careful to decide which one do we have to choose. If the patient is coming only for regularity or irregularity of the mens, then in that case, if we use the levonorgestrel IUD, would be better choice as cyclic progesterone. And if the patient is overweight, because OCP comes with that overweight, but it's always the first best choice if tolerated or if the patient chooses to use it. It's always the first choice. But if the patient is overweight, the patient prefers something that does not cause overweight, then you can go with the levonorgestrel. If the OCP is contraindicated, or for any reason, if the patient is overweight and does not like the OCP. For hirsutism or acne, if the patient is specifically asking you, usually it's a combination treatment, But if the patient is also having too much hirsutism, acne, which usually they will, so you have two options doing DINE-35, which is a combination, but in terms of potency, it is not as potent, as flexible as combined OCP plus spironolactone. You can use a spironolactone in cases where the OCP is contraindicated. You can use it as a monotherapy. Usually, spironolactone is used as a combination with the OCP to get the best result out of the treatment. But in some cases, maybe your patient has some sort of allergies, or the patient, for example, is not a good candidate. For example, the patient has DVT, or the patient is having a migraine with aura. In that case, you cannot use the OCP. So you can go ahead and do the monotherapy with the spironolactone. Topical L-carnitine is an adjunctive treatment only for the hirsutism. Letrozole, if your patient is in your clinic and the main concern is about fertility, so always go with letrozole first. It's the first best choice, and the second best choice is clomiphene. Metformin is adjunctive treatment or option. For the key MCQ E1 tips, always exclude the secondary cause. So this is an exclusion diagnosis. So you have to exclude all the possibilities. OGTT for glucose screening, not hemoglobin A1C alone. It doesn't mean you cannot do it. You can do it, but it's always better to use the OGTT. In adolescents, do not rely on ultrasound. Need hyperandrogenism plus oligo and ovulation over 2 years post-menarche. Spironolactone is safe monotherapy when the OCP is contraindicated, which I did give you an example. For example, your patient has DVT, so you cannot use the OCP. You can go ahead and do a monotherapy with that spironolactone. And to protect the endometrial, levonorgestrel, IUD, or Mirena will be the best choice. Take home diagnosis, it's exclusion plus 2 out of the 3 Rotterdam criteria. And what is Rotterdam criteria? I just give you the mnemonic, which is PCO, right? So PCO. Always screen for the metabolic syndrome and diabetic. Individualize the treatment based on the fertility plans, symptoms, tolerability of the estrogen, protect the endometrium to prevent hyperplasia, and oligo and ovulatory patient. Why? Because the PCO candidate the patient into what? Endometrial hyperplasia and endometrial carcinoma or cancer. So DINE-35 and OCP plus spironolactone, they are both treatment. But let me show you this. I think this would give you a good idea of differential diagnosis. So DINE-35 and is OCP plus spironolactone. So both of them are doing the same thing, but this is more potent, more flexible, and it can be adjusted in terms of dosing depending on the patient's response. But this one is fixed. It's a fixed combo. So it's less flexible. This is more flexible. You can change, you can add, you can decrease, you can increase the dose as you wish. So I made a high-yield flashcard about the PCOS that if you get question from the PCO, you will definitely get one of these questions. If you know these stuff that I provided and prepared for you guys, and if you know them, you should be good. So you're not gonna make any mistakes when it comes to any case or scenario about polycystic ovarian syndrome. So what are the key hormonal imbalance in PCO? Insulin will go up. FSH lower, LH higher, androgen will be high. Anovulation, hirsutism, infertility, high estrogen via peripheral conversion, endometrial hyperplasia is the risk that comes out of hyperestrogenism. What are the Rotterdam criteria? PCO. Rotterdam criteria for PCOS is the PCO. P stands for polycystic ovaries on ultrasound, more than 12 follicle or more than 10 millimeter volume, ovary volume, right? Clinical, C stands for clinical biochemical hyperandrogenism, like hirsutism, acne, and so forth and so on and so forth. Oligoamenorrhea, more than 6 months. Or the patient will have in total of 8 cycles per year. What are the common clinical features of polycystic ovarian syndrome? Irregular mens, hirsutism, acne, infertility, obesity, acanthosis nigricans, insulin resistance. What lab should be ordered in suspected PCO? We have to do the TSH, prolactin, 17, hydroxyprogesterone, LH, FSH ratio, which will be more than 2/1, free testosterone, and DHEAS, lipid profile, OGTT. These are all the investigation we need to do. What is the classic ultrasound finding in polycystic ovarian syndrome? String of pearls. This is how it looks. String of pearls. And this is how it looks like. More than 12 follicles, 2 to 9 millimeter, or ovarian volume more than 10 cc or 10 milliliter. How is the menstrual irregularity managed in PCOS? Weight loss, exercise, combination of OCP, cyclic progesterone, hormonal IOD, Mirena, metformin, if insulin resistance present, which usually is. What is the first line treatment of infertility? If it is infertility in polycystic ovarian syndrome, letrozole. What is the second line? Clomiphene, plus minus metformin. Specialist options include gonadotropin or ovarian drilling. How is hirsutism treated in polycystic ovarian syndrome? The OCP, combination of the estrogen and also anti-androgen, which is diene-35, Yasmin, or OCP plus spironolactone. Finasteride, fulotamide, mechanical removal, avoid in pregnancy the finasteride and fulotamide. Note, I think I have this one even more in details. So the diene-35 contains seproterone acetate and anti-androgen and ethinyl estradiol. What are important conditions to rule out in polycystic ovarian syndrome, like presentation, the late onset of congenital adrenal hyperplasia, Cushing syndrome, androgen secreting tumor, hyperprolactinemia, hypothyroidism. So you know what to do, right, in the lab. What are the long-term risks in polycystic ovarian syndrome? Type 2 diabetes mellitus, endometrial hyperplasia and cancer, infertility, sleep apnea, obesity, hyperlipidemia. So what are some high-yield clinical pairs for the PCO? Letrozole is more common and preferred than clomiphene for fertility. Always check TSH, prolactin. Acanthosis shows insulin resistance. Adolescent needs 1 to 2 years post-menarche before diagnosing. So it means you have to give them at least 2 years. Then you can go ahead and do the investigation for PCOS. If she is presenting with symptoms like PCOS, protect endometrium in women with irregular cycle with the Mirena. So this is a chart that shows the differential diagnosis between non-classic congenital adrenal hyperplasia and polycystic ovarian syndrome. They're almost the same thing when it comes to differential diagnosis. The two important things that I would like to mention is about the testosterone, because usually when they come to you, they will have the same presentation. But when you do the lab test, two things that you can easily differentiate them is the testosterone and the level of the DHEAS. The level of DHES often normal or mildly elevated in polycystic ovarian syndrome. However, it's elevated due to adrenal overproduction. It will be very high in congenital adrenal hyperplasia. Free testosterone will be mildly high or moderately high, but it will be mildly high in congenital adrenal hyperplasia. It means testosterone in polycystic ovarian syndrome will be higher than congenital adrenal hyperplasia, but DHES will be higher than polycystic ovarian syndrome. Okay, the rest I will let you guys to go ahead and read it when you get the chance and when I uploaded the notes in your account. These are some observation I would like to, okay, I think I should add the line here. It should be good now, yeah. It's
The
good.
one that says OHP must be HOP.
Okay. Yes, John, whatever you have, can you write it down and then we'll talk about that at the end. This is also the abbreviation for, oh, now it's better. It's the same thing. Yeah, I think it's the same thing. Yeah. All right, let's move on to gynecological infection and vaginal discharge. This is also very high yield. You will definitely 100% get 1, 2, or probably even 3 questions out of this topic. Very high yield. So I really encourage you guys to go ahead and read this when you get the chance, and I will definitely upload these notes in your account. So normal physiological vaginal discharge. Appearance will be clear, whitish, and odorless. Microscopic, predominantly epithelial cell and lactobacilli. Cause the estrogen dominant state, mid-cycle, pregnancy, OCP, and polycystic ovarian syndrome, premenarchal. In postmenopausal woman, new discharge, if you have a patient who is postmenopausal and suddenly appears or presents with a new discharge, may suggest atrophic vaginitis or malignancy. Usually it will be due to lack of estrogen. So bacterial vaginosis, in terms of vaginal infection, these are very, very common and they are commonly tested. Bacterial vaginosis, candidiasis, trichomoniasis, chlamydia, gonorrhea, atrophic vaginitis. So the discharge are different. For bacterial, if you notice, I even changed the color to gray because the type and the color of the discharge is gray. It will be thin, gray, white, and fishy odor. And the pH is also important. It can help you and support you in diagnosing the right vaginal infection. It is more than 4.5. Clue cell is very characteristic finding, and the treatment is metronidazole orally for 7 days. Candidiasis, it will be thick, white, cottage, cheese. So they will mention this. Irritation is very common. Itching and pseudohyphae is very characteristic finding. It's the key finding. So fluconazole is the best choice. You can have only one dose, a single dose of 150 milligram, or you can use a topical one. But the thing is about the candidiasis that if you have somebody who is immunocompromised, who has been using a long-term steroid, or the patient has diabetes mellitus, and the patient is experiencing recurrent candidiasis, the treatment is different. So it's always a single dose fluconazole. But for those patients, special conditions like immunocompromised or recurrent cases, which the patient experiences 4 or more than 4 episode of candidiasis, the treatment is different. You give them a single dose for 3 days. For 3 days, 150 milligram per oral, first day, then second day, then third day. Then you switch it to weekly. The patient is taking the same dose, but weekly for 6 months. This will take care of the recurrency of the candidiasis. Trichomoniasis frothy. This is a key word that they are using. Frothy, green, yellow, foul smelling. And the reason I made the color green because this discharge will be green color. And strawberry cervix will be also mentioned in the clinical finding. Motile trichomoniasis or this keyword motile will be mentioned in the motile trichomoniasis or protozoa will be mentioned in the scenario. The treatment is the same as bacterial vaginosis. The only difference is that with trichomoniasis vaginalis, you use only a single dose of 2 gram metronidazole. Not only for the patient, you have to use the same dose for the partner. But for bacterial vaginosis, it is orally 500 milligram BID for 7 days. But for this one, it's just single dose of 2 gram for the patient and the partner. Chlamydia and gonorrhea, purulent, mucopurulent discharge. The pH will be variable, often asymptomatic, or the patient will come with a clinical picture of PID, in some cases even with a Reiter syndrome or reactive arthritis. The patient will come with a urethritis discharge, and also with a monoarthritis, and a little bit like maybe here there fatigue and fever, mild, and then you can diagnose the patient with a Reiter reactive arthritis and treat accordingly. And the treatment is doxycycline and ceftriaxone. One thing that I would like to mention here is the ceftriaxone dose is now increased. As of 2025, the ceftriaxone dose is no longer 250 milligram, it is 500 milligram. It used to be 150 milligram plus doxycycline 100 milligram BID for 7 days. Then they changed it to 250 milligram IM ceftriaxone, same dose of doxycycline for 7 days. Now you have to use 500 milligram ceftriaxone IM with a doxycycline, same dose as before. Atrophic vaginitis, watery yellow, irritation, the pH will be always above 5.5. Pale mucus and vaginal estrogen or topical estrogen will be the treatment. Red flag for PID. Present with the pelvic pain, cervical motion tenderness is the key characteristic clinical finding, plus fever. Considered in a sexually active woman with a new partner or multiple sexual partner. Treat empirically, ceftriaxone, doxycycline, and metronidazole. So the patient has PID, 3 letters. The patient will use 3 antibiotics, ceftriaxone, doxycycline, plus minus metronidazole. Okay? This is how you can remember it. Approach to vaginal discharge on MCQ-A1. History. Everybody knows what to do on the history, OCD, PQRST, COCA-P, and physical examination, valvular inspection, speculum, bimanual, if indicated, investigation, vaginal pH with mount microscopy. It's not very specific, but very helpful in supplementing or completing your diagnosis. NAT, remember the NAT for sexually transmitting infection. This is the best and confirmatory test. If they test you, they will definitely test you on NAT. Pap test or biopsy if malignancy is suspected. Take home. Bacterial vaginosis is the most common cause of abnormal discharge. Maybe I should put this in a red color. Candida usually thick discharge, thick whitish discharge. Maybe I should put white here. Whitish discharge. And normal pH. Okay, I can't make this one white, but I can make it a different color. Okay. Trichomoniasis, sexually transmitting frothy discharge is the very characteristic or clinic symptoms that they will mention in the scenario. Always treat the partner with the metronidazole. This is very important. I cannot make it different color, but anyway, PID clinical diagnosis. Do not delay the treatment. Atrophic vaginitis and postmenopausal. Think about estrogen deficiency and treat it accordingly with a topical estrogen. So these are the type of vaginal discharge in terms of the color and how it looks like, consistency. So I let you guys take a look at it when you get the chance. So vulvovaginitis, again, another high yield topic. Vulvovaginitis refers to inflammation of the vulva and vagina, commonly presenting with vaginal discharge, odor, itching, and irritation or discomfort. This is normal vulva and vulvovaginitis. This is how it looks like when it is irritated and inflamed. Obviously, it will be reddish, swollen, and painful. Common causes. Again, I don't want to waste your time. Something that I did not get the chance to mention is when you have a patient who is foreign body in children. So I'm talking about the children patients, the pediatric. So let's say you have someone like 3 years old or 4 years old comes with a vulvovaginitis, or the patient has discharge. So always rule out the child abuse and sexual abuse first. Once that is out of the picture or out of the window, then see if the patient has foul smelling and bloody discharge. If the patient has foul smelling and bloody discharge, it could be foreign body. Usually the valvular erythema, possible trauma, other finding, rule out abuse, always rule out abuse. And if you cannot find the foreign body, you have to do it under anesthesia. Exam under anesthesia. Okay, approach to workup for the vulvovaginitis. History, again, you have to do the OCD PQRST, and if the patient has discharge, glucose B supposed to be covered. And investigation, same thing, the wet amount, vaginal pH, and if you're suspecting to sexual transmitting disease, you can still do the NAC. So the treatment, I think I did mention about metronidazole, 500 milligram BID for 7 days. Candidiasis, this is a single dose unless the patient is immunocompromised. If the patient is immunocompromised and also the patient has recurrent, what do? You give him 3 doses for 3 days, then switch it to weekly for 6 months. Okay? Trichomoniasis, only a single dose of 2 grams for the patient and a single dose of 2 grams for the partner, but this one you have to report. This one you have to report it to public health. Not only this one, all sexual transmitting disease should be reported to the public health, including trichomoniasis vaginalis. Recurrent candidiasis, fluconazole. Okay, yeah, here. So you do the same thing, same dose, but for 3 days, 3 doses, then give them the same dose weekly for 6 months. So I thought I didn't mention it. Atrophic vaginitis, we know. We gave them topical estrogen. Bacterial vaginosis in pregnancy. Remember, during pregnancy, bacterial vaginosis, if the mom is asymptomatic or symptomatic, it doesn't matter. Regardless of the symptom, you have to treat the patient. Treat if symptomatic to reduce the risk of the preterm labor, but for pregnancy, even if the patient is asymptomatic, you have to treat it. So bacterial vaginosis, if the patient is symptomatic, treat. But for pregnancy, regardless of this, I have to change this. Treatment is regardless of the symptom. Whether the patient is symptomatic or asymptomatic, you have to treat the patient. So let me treat regardless of the symptom. Treat it regardless of the symptom. If it is positive, you have to treat it. Trichomoniasis vaginalis, always screen and treat the sexual partners. Okay? Trichomoniasis, always treat the sexual partners. Remember, for bacterial vaginosis, you don't have to. For trichomoniasis, you have to report to public health, and also you have to treat the partner. Foreign body in children, consider in persistent smelly discharge, or maybe smelly and bloody, I have to add, and bloody discharge. Okay. Refer to exam under anesthesia. So EUA, exam under anesthesia. Recurrent candidiasis, if the patient has 4 or more than 4 episodes of candidiasis in 1 year. Need maintenance therapy plus adverse risk factor. Usually the patient who has recurrent candidiasis will be immunocompromised patient, diabetic patient, and also somebody who is taking using tight clothing or has poor hygiene, or somebody who is taking long-term steroid or long-term and unnecessary antibiotic. So here I did mention antibiotic. It's a little bit vague, maybe long-term. I should long-term and unnecessary antibiotic. So it can cause what? Candidiasis. Strawberry cervix plus motile organism, trichomoniasis, with test if it shows clue cell is for bacterial vaginosis. Normal vaginal pH is between 3.8 to 4.5, which is acidic. So if it is above that, suggests bacterial trichomoniasis. Or if it is above 5.5, it will be atrophic vaginitis. These are the abbreviations in case you guys have problem with the abbreviations. Sexually transmitting infection. So I think we did somehow mention it, but in details, I think it is also high yield. I can mention it here. Chlamydia is the most common bacterial sexual transmitting infection. Neisseria gonorrhea, often co-infection with chlamydia. So if they ask you which one is the most common sexual transmitting infection, always go with chlamydia, especially in Canada. And Neisseria gonorrhea is usually coexist with the chlamydia. If you have a patient who has chlamydia, always treat the patient with ceftriaxone and doxycycline to cover for the Neisseria gonorrhea as well. If you have a Neisseria gonorrhea, you can treat the Neisseria gonorrhea on its own, but if you have chlamydia, you have to treat the Neisseria gonorrhea along with the chlamydia. Trichomonas vaginalis, more common protozoa, sexual transmitting in women. So if they're asking you about the most common bacterial, chlamydia. If they're asking about the most common protozoa, Trichomonas vaginalis. If they're asking you about the most common virus, then you can talk about or mention about the HPV. Herpes simplex, HPV, HIV, syphilis, important viral sexual transmitting infection with a systemic implications. And these are the pictures that help you to understand a little bit more about these organisms. Chlamydia often asymptomatic, especially in women. Mucopurulent discharge, postcoital bleeding, urethritis. So if somebody has urethritis and the patient is asymptomatic, think about chlamydia because it often happens, but it will be asymptomatic, especially in women. Or they may have symptoms like fatigue, things that we usually have on daily basis, like tiredness, fatigue, flu-like sinus symptoms. Sometimes we have aches and pains, right? Something like that. So think about chlamydia. If the patient is 25 or less than 25, sexually active, multiple sexual partner, then you have to be strongly suspected to chlamydia. Gonorrhea, purulent cervical urethral discharge, dysuria, pelvic pain, trichomoniasis, frothy yellow green vaginal discharge, strawberry cervix. I think you did talk about this. Syphilis, painless chancre or painless ulcer. So for the primary, it will be painless. For the secondary, the patient will have papular rash, and the patient will have rash in the palm and sole as well. And usually the secondary happen within 3 to 6 months after primary, if primary is not treated. So usually it happens within 3 to 6 months of the primary. Tertiary could happen years after secondary if not treated. Aortitis and cardiac complication, they usually happen years after untreated primary and secondary syphilis. For the primary, remember, use only one dose, a single dose of penicillin, 2.4 million, benzathine penicillin. For the secondary, you can also use a single dose of penicillin, benzathine penicillin, 2.4 million. Then we have here a latent phase. A latent phase is in two categories. One is called early latent, one is called late latent. So the early latent is when the symptoms or the secondary syphilis symptoms appears less than 1 year. You can still use a single penicillin, benzathine, penicillin 2.4 million. But if the symptoms is over 1 year, it is called late latent syphilis. Then in that case, for the late and tertiary and neurosyphilis, for tertiary, you have to use 3 doses of benzathine penicillin 2.4. For neurosyphilis, then you have to use the IV. For investigation, NAT, again, the golden standard confirmatory for chlamydia, gonorrhea, and trichomoniasis. Wet, it's very low sensitive, but it's very helpful. For syphilis, remember, if you have a patient with syphilis, pay attention to the question. What is this asking you? If it is asking you what is the best screening test, go with the VDRL and RPR. If they're asking you what is the confirmatory test, go with the FTA ABS. Just pay attention to the question. We always get it wrong because we think that it's asking us about the same thing. No, probably they're asking you about the screening, not the confirmatory. So if they're asking you about the screening, go with the VDRL and RPR. If they're asking you about the confirmatory, go with FTA ABS. Herpes simplex, they will definitely ask you this, and the PCR or viral culture for the lesion. HIV, HPV blood test, or PAP, HPV co-testing. For the treatment, for chlamydia, azithromycin 1 gram per oral, or doxycycline 100 milligram BID, 7 days. But we have to avoid doxycycline for pregnancy. Gonorrhea, ceftriaxone 500 milligram. It used to be 250. Now it's 500 milligram IM plus azithromycin 1 gram or doxycycline 100 milligram BID for 7 days. It's up to you guys. Trichomoniasis, same thing as before. Syphilis, benzathine penicillin, 2.4 million. I have to add it. I think I forgot. But remember, for neurosyphilis, so for somebody who has syphilis and the patient is non-pregnant and the patient is in primary and secondary phase of syphilis, in that case, you can use benzathine penicillin. So let's say the patient is allergic to penicillin, the best choice will be doxycycline. But you cannot use doxycycline for pregnant patient who has syphilis. You cannot use doxycycline for somebody who has neurosyphilis because it's not as strong, as potent, as effective as penicillin. So in these two specific conditions, if the patient is allergic to penicillin or has allergy to penicillin, desensitize the patient first, then use the penicillin. Pregnant and neurosyphilis. For herpes simplex virus, acyclovir, pamciclovir, valacyclovir. So you choose, I think acyclovir is most commonly used one. For the HPV, podophyllin, cryotherapy and surgical removal. Gardasil is the vaccination. We will talk about it based on the age and if the patient is immunocompromised or compromised, how we're going to set the vaccination. So partner notification and reporting. Reportable sexual transmitting infection in Canada. Chlamydia, gonorrhea, syphilis, HIV, and trichomoniasis vaginalis. These are reportable and you have to report it to public health. Okay, so if you have these sexual transmitting infection, report. Test and empirically treat all partners within 60 days of the diagnosis. For all sexually transmitting infection, you have to empirically treat the partners within the 60 days of the diagnosis. For example, chlamydia and gonorrhea. But how about the abstinence from the sex? Until both patient and the partners are treated and symptoms resolved. Okay, so within 60 days, you have to treat the partners and they cannot engage in any sexual activity until both the patient and the partners are completely free of symptoms. The screening recommendation per Canadian guideline. All sexually active individual less than 25. If we have any patient, the age is 25 and less than 25, annual screening for chlamydia and gonorrhea. Okay, annually, every year they have to be screened for chlamydia and gonorrhea if they're sexually active. So all sexual active individual. Pregnant woman, routine screening, early and repeat the sexual transmitting infection in third trimester if high risk. For men who have sex with men, frequent testing every 3 to 6 months. The risk of sexually transmitting infection in men who is engaging in sexual activity with other men is very high comparing to heterosexual population, so they have to do their screening more frequently. People with new or multiple partners or previous sexually transmitting infection also has to go through the screening, HIV screening, and high-risk individual and all pregnant women. Complication, PID, infertility, it causes infertility, ectopic pregnancy, chronic pelvic pain. Fitzhugh-Curtis syndrome is another complication, or they may mention prehepatitis. Rider syndrome is a complication of chlamydia, especially in HLA-B27 plus male. Neonatal infection, conjunctivitis, which gets it from mom, chlamydia, gonorrhea, and pneumonia due to chlamydia, and encephalitis from herpes simplex virus. Take home, think chlamydia in young asymptomatic patient with a mild symptom or post-coital bleeding. Young, sexually active. I should mention that. Young and sexually active. And sexually active young and infant. Maybe I should put in sexually active. In sexually active young asymptomatic patient with a mild symptom or post-coital bleeding. Always screen and treat the partners to prevent reinfection. Used not for accurate diagnosis of sexual transmitting infection. This we know. And know which is sexual transmitting infection are reportable. We know chlamydia, we know gonorrhea, we know HIV, syphilis, right? And trichomoniasis vaginalis. And differentiate trichomoniasis, candidias, and bacterial vaginosis uh, in case of vaginitis based on the discharge and the pH. We all know that. Let's see if we are done. Okay, HPV. HPV, it's the most common viral sexual transmitting infection in Canada, as we have protozoa trichomoniasis and we have bacterial chlamydia. This is the viral all over the world, especially in Canada. Transmitted via vaginal, anal, oral, and even non-penetrative sexual contact. So it has a lot of types. The most common type that causes the anogenital warts is 6 and 11. And the one that causes the cancer is 16 and 18, and all others, but mostly 16 and 18. If they test you, they will test you on these one. And it can cause cervical, valvular, vaginal, anal, penile, and oropharyngeal cancers. Clinical presentation, asymptomatic, latent, most common, detected via screening, anogenital was, condylomata agumenta, painless. Cauliflower is a keyword. They will definitely use this in the scenario. Cervical dysplasia or cancer may present with abnormal bleeding or be found on pap smear or pharyngeal lesion, considered an persistent sore, visible tonsil mass. Now, this is how it looks like in the hand, mouth, and a genital area as well. So for the investigation, Pap test detects squamous intraepithelial lesion. Screening starts at the age of 25, and usually you repeat it if it's normal every 3 years. HPV DNA testing for woman 30 or with an abnormal Pap reflex testing helps risk stratification. Biopsy any suspicious resistant or atypical lesion, especially in valvular, anal, or oral area. Colposcopy for persistent high risk of HPV, abnormal cytology, or visible cervical abnormalities. So if you have any abnormalities in these two tests, you go with colposcopy. So it is a little bit tricky. It's not this easy to finalize it, but yeah, for example, if somebody has an HPV and the HPV is positive, what you do next, you don't do nothing. You just repeat the test in 12 months. So if the HPV is positive, usually, mostly the patient will, if the immune system will take care of it within 12 months. If after 12 months, the HPV is still positive, then you go with colposcopy. Okay. Management, the genital ward, there is a mnemonic that I call SEP. So for the patient applied, so when it comes to genital wart, there are two ways of treatment. One, the patient herself or himself will apply the medication, and one is done by the physician or by the healthcare provider. So the one that is applied by the patient is SIP. S stands for sinecatechicine or catechins, and I stands for imiquimod, which is the most common one and the best one if they ask you out of all these three, and the P stands for podophylox. Okay. For the clinical or clinician administration, cryotherapy, trichloroacetic acid, and surgical removal. And if they're asking you for the clinician administration, which one is the best one? Cryotherapy. Cryotherapy is the best one. It's also safe in pregnancy, the trichloroacetic acid, but the cryotherapy is the best one. In either it is done by clinician, or if it is it's always done by the clinician. So for the one that's done by the clinician or healthcare provider, if they're asking which one is the best one with the best result, cryotherapy. The one that's applied by the patient, which one is the best one? Imiquimod. Okay. Abnormal PAP or HPV plus result referred for colposcopy if high-grade cytology or persistent high risk of HPV. So again, let me revise what I said. So if you have an HPV positive, but cytology is negative, you just have to wait for 12 months. Repeat the HPV after 12 months. If the HPV is negative, you're good, then you have to keep on doing the HPV every 5 years. But if the HPV is positive, then you have to do colposcopy. Or if you do the HPV, it is positive, and also the pap smear is positive, then you have to do the colposcopy. Okay? Prevention, HPV vaccination. Gardasil 9 protects against 9 high and low risk types. Routine for all individuals from 9 to 26 for female and up to 45, 9 to 26 for male and up to 45 for female. So if they specify it for female, it is up to 45. If they are specifying it for male, it is up to 9 to 26. Condom reduces transmission, but not fully protective. Okay, so they may ask you about this, that does the condom help? It helps, but not all the way or completely. So the key for the exam that you have to remember, persistent high risk HPV, 12 or more than 12 months of HPV, also again positive, colposcopy, even the cytology is normal. Postmenopausal woman with a valvular lesion, biopsy. If you have postmenopausal woman with a valvular lesion, any lesion after menopause is considered malignant until proven otherwise. So you have to do biopsy to rule out malignancy. HPV vaccination is preventive, not therapeutic. So it has to be done when? Before the patient is sexually active or before the first sexual activity. Pap smear screening start at 25, age of 25, and it's done as before every 3 years, if normal. Okay, this is a chart. I think I did mention everything about this, but this is very important. This part is very important based on age. So usually the IMGs get this wrong because they do not memorize these ages and the timing. The ages and the doses. So approved age for female, it is 9 to 45. For male, it is 9 to 26. Administration time should be administered before onset of sexual activity. This is also part of the question. So they may ask you, I have very strong feeling that they may ask you this, before exposure to virus. So conception attempts. So if somebody gets the vaccination, when they should start trying to conceive, conception should be avoided until 30 days after last dose of vaccination. Okay, so try to educate your patient that this is the last dose of your vaccination. Try not to have kid at least for a month. After a month, then you can try to use condom, try to use any sort of contraception for at least 30 days. Then you're good to go. Okay, this may be in the exam. So regular patient, I mean the patient who is not immunocompromised. So what do you do? If the patient is from age 9 to 19, the patient usually gets 3 doses, 0 to 6 months. 0 to 6 months. From 19 to 20, they receive only 1 dose. If you get a patient who has never got the vaccination, newly landed, 19 to 20, 1 dose. From 20 to 45 for female, 2 doses. Now, the case is different for immunocompromised patient. Now, if your patient is immunocompromised 9 to 20, the patient gets 2 doses. From 20 to 45, the patient receives 3 doses. This is also a little bit, so basically this chart is all about this, and this is the short form of it. It summarizes everything you need to know.
I wish it had a male and female in front of it so that we could know on the colored ones.
Here, So when it has
Mhm.
45, it's all 100% female. If it is
Okay.
not, if it doesn't have 45, it is definitely male.
Okay.
Yeah, because 45 is only for female. Cervical cancer screening guideline, March 2025. Okay, so 25 to 69 HPV test with reflex cytology every 5 years. This is the new guideline, March 3, 2025. For anyone who is between 25 to 69, the HPV is the primary test with the reflex cytology. It doesn't mean we don't do the pap smear anymore. We do it, but it's not the primary anymore. The HPV test is more the primary now. And then repeated every 5 years, applied to individuals with a cervix who have ever been sexually active and are asymptomatic. Immunocompromised HPV test with the reflex cytology every 3 years. This is different for someone who is immunocompromised. This is 3 years. But for regular patient, it is 5 years. HPV positive result, reflex cytology performed as per clinical pathway, negative HPV result, no further action, return to screening and every 5 years. So screening option for women age 25 to 65, again, same thing. You still do the pap smear, but it's not the primary. Herpes simplex, etiology, herpes simplex type 2, 90%, around 90% is the most common cause of the genital herpes. They may ask you about which one is common in genital area. So herpes type 2, about 90% is the most common cause of genital herpes. One, about 10% increases due to oral genital contact. So if they're asking about the genital, the herpes simplex virus type 2. Clinical features, primary infection, first exposure, often asymptomatic. Incubation is 2 to 12 days. Prodrome tingling. Usually when you start the medication, as soon as the patient starts this, not even the burning, the tingling. When the tingling starts for somebody who has recurrent history of herpes simplex, you have to start the treatment. Further, as soon as the patient says that I'm feeling tingling, okay, this may be in your exam. Lesion, painful, groove, physical, shallow ulcer on the vulva, vagina, cervix, associated with symptom, fever, malaise, inguinal lymphadenopathy, dysuria, urinary retention. Recurrent infection, less severe, shorter duration, more common with the type 2. Investigation, this is very important, most sensitive, rapid, especially in vesical ulcer present. A viral culture, only early in course. T-zunk smear, obsolete. They used to do it especially for the varicella and herpes simplex as well, but it is obsolete. It means they are not using it anymore. So herpes simplex serology, not useful in acute diagnosis, limited role, and counseling. The treatment, acyclovir 5 times a day, 200 milligram for 7 to 10 days. For recurrent, 500 milligram acyclovir, 1 gram per oral for 5 days. Suppressive for recurrent, uh, usually if it is more than 6 recurrence per year or recurrent every 2 months, valacyclovir 500 to 1000 milligram per oral daily. Severe infection, in this case you give them IV. Counseling, avoid sexual during prodrome and active lesion. Condom reduce, but do not eliminate. This also may be in the exam because people think that if I use the condom, I'm safe. It reduces, but it does not eliminate the rest. Partner disclosure and sexual transmitting screening are essential. Screen for co-infection, HIV, syphilis, chlamydia, and gonorrhea. So once the patient is positive for herpes simplex, they have to be tested for that coexisting or co-infection, coexisting of other sexually transmitting infection, especially the virus, HIV, and also the chlamydia, which is the bacterial, gonorrhea, and syphilis. Differential diagnosis, painful ulcer, chancroid, painless ulcer, syphilis, chancre, multiple recurrent oral or genital ulcer, consider Bassett disease, which is non-infectious disease. Take home is herpes simplex virus is a lifelong with intermittent reactivation. Primary genital herpes simplex virus can mimic UTI or vulvovaginitis. Always test other. We mentioned this. So in pregnancy, herpes simplex may require suppressive treatment. Remember, if you have a patient who has herpes simplex, I know, I'm going to stop. If you have a patient who has herpes simplex and the patient is pregnant, then you have to do the suppressive treatment starting at 36 weeks of gestation. And that's the end of our lecture. Still, we have to go on, but I think Dr. Setvolot said it's too much. All right.